Welcome everyone to our third clinical chat now rather than tendon talk. We've branched out, Dan. So we had a question last week about clinical tests. So we came up with the idea of exploring that in a bit more detail. So we're going to have a look into sensitivity, specificity, validity, and reliability today. Hi everyone. So we've got Rebecca, Peter, and Dan on the chat. Hi guys. So I'm going to hand over to Dan. Dan's going to talk about sensitivity, specificity first, and then I'll follow up with validity and reliability. Over to you, mate.
All right. Thank you, Mike. Right. So welcome, everybody. I'm just going to start the presentation here and then see if I click on attendees now, Mike, can I see or question chat? It's chat, isn't it, with the questions?
Yeah, chat with the questions. Yeah.
Yes, there we go. Brilliant. Okay, great. A few people here. So welcome everybody to our weekly chat. And today, as Mike said, we'll be looking at special tests, which is a very topical and in vogue subject at the moment, because special tests are something that we've been taught for many, many years from our basic beginning studies. As we start studying on university or weekend courses, etc., we're taught tests for the knee, tests for the shoulder, etc. And in particular, tests for the shoulder, there's almost 100 different tests that you can do for the shoulder. However, with a lot of special tests, recently it started to come to light that the special tests are not as special as we once thought, and that they don't give us the conclusive answers as to what's going on with our patients. So Mike and I are going to have a discussion about that today, and I'm kicking off with what you can see on the screen here, which is false positives, false negatives, sensitivity, and specificity. Okay, so sensitivity is something that my wife tells me I've got bundles of. It's not true. And specificity is something that is definitely a challenge to say after a few beers or a couple of glasses of wine. So let's start with false positives and false negatives. Okay, so let me press the button here. And I hope you're all wearing trousers, by the way, guys. You saw the advert. I see all these people coming on Zoom and not wearing any trousers.
My Sunday best on.
Yeah, I've got some trousers here. Do you want to see my trousers? There we go. There they are. I've got shorts on. It's warm.
You live in Cornwall, of course you have.
Exactly. False positives. False positives are quite simple. It's when the test is positive. So let's say you do a test for the medial ligament of the knee, the MCL ligament test, and you get a positive test. So the person says, ouch, that's painful. Then a false positive would be you get that result, but they don't actually have an injury to that ligament that you think you've just tested. You may do a NIRS test of the shoulder, so elevating the arm right up above the head, pushing into end of range. Patient says, ouch, that's a positive test, but the pathology may not be present. They may not have a tendon, rotator cuff tendinopathy, call it impingement, whatever. They won't have that there. So when you do a test and the test is positive, it's a false positive if they don't actually have that condition. And how do you determine that? Well, commonly in the research, that's determined by gold standard imaging, which is MRI studies, which we can talk about a bit more later. So that's a false positive. It's getting a positive result when actually it's not there. The opposite to that, of course, is false negatives. So here you do a test and the test doesn't cause them any problems. There's no laxity in the joint, or they don't report any pain. However, they actually do have a pathology present in that case. So let's just say you do the Thessaly's test, also known as the disco test. This is the one where you stand the patient on one leg, slightly bend the knee, and get them to twist. This would stress the meniscus tissue in the knee. If you did that test and it didn't cause them any problems, that would be a negative test. But it doesn't mean that they don't have a meniscal injury. So if they still had a meniscal injury and you tested them with that test and that test showed negative, you'd have there a false negative, because actually the test should have been positive. So it's a false negative. So there's the false positives and false negatives. And then that brings us on to look at the two statistical measures of sensitivity and specificity. So these are quite easy to explain. but you actually use them in the reverse way. So let's just start by looking at sensitivity, and I'll give you an example here on the screen. So the sensitivity of a test is the ability of that test to detect the target condition. In the picture here, you can see that I'm doing a knee test. I won't ask you to guess which one that is. It should be quite obvious. It's stress testing the inside of the knee, the medial collateral ligament. And the sensitivity of this test, I don't know what it is, but one study from 1986 suggested that it was 86%. So what does that actually mean? Well, that means that if 100 people had a medial ligament injury, this test would detect 86%, or would detect a positive in 86 of those 100 people. Okay, so that also means, of course, that 14 people would be missed. So its sensitivity being 86% is very good, but you'd still miss 14 out of 100 people with the use of this test. So its ability to detect the target condition. That's how sensitive the test is. Now we're going to spend a bit more time on these, but firstly, let's balance that with the other statistical measure, which is specificity. This is the opposite. It's the ability to exclude the target condition. So on the screen here, you can see a classic test, the anterior draw test, commonly used for the ACL ligament. And if you did this with all patients that didn't have this issue, then you essentially should have a negative from all of those tests that you did. However, a study reported that the specificity of this test was 41%, which means you're going to get a lot of false positives from doing this test, and it's not actually that specific for detecting the problem. So we're going to look at this a bit more, in a bit more depth now, and help you to actually understand how you use it in clinic. Because I think that's always the important thing is, what does this mean in clinic? How can we use this in clinic? So a high sensitivity helps you to rule out the condition. I'm just going to go back a couple of slides. So we've just said that sensitivity is the ability to detect the problem, to detect the pathology, the target condition. So a high sensitivity helps you rule out the problem, because if you test them and the test is negative and it's a very highly sensitive test, then it's most likely that the condition is not there because the test is negative. The test has a high sensitivity. The high specificity helps you to rule in the condition. Okay, so if you test them and the test is positive, then it helps you to identify that the condition is probably there, because the test is being very specific to what you're trying to test it for. I'm going to help you understand that a bit more in clinic, and this is if you use these two acronyms, SNOUT and SPIN. So SNOUT is built out of the text that it is explaining below the acronym there. If it's a highly sensitive test, then when it's negative, it rules the diagnosis out. So therefore, sensitive is negative. There's sensitivity, negative rules it out. If it's a highly specific test, then it's SPIN is the acronym to use. So if it's a highly specific test, when it's positive, it rules the diagnosis in. So you've got SN for the representing sensitivity, negative rules it out. High specificity, positive, it rules it in. So those are the two measures and how you can use those in clinic, ruling out and ruling in. Just a couple other things I wanted to mention there, Mike, but they're for the end of the session. So I'll let you do your bit now. And Brilliant. Then I just want to show those couple of slides at the end.
No, that's great. Thanks, Dan. So just going to switch slides over a second. Okay, so So I'm going to have a look at validity and reliability of tests, and I found a nice article. I was looking for a chap called Chad Cook, and it's with some other people as well. He said clinicians should quit looking for overly simplistic answers. Clinical diagnosis like producing a great wine, so it's complex, requires an appreciation of the data that can be gathered within the nuances of patient interaction. And I thought that kind of summed up today's session quite nicely, because some of the, like Dan said, the special tests aren't very special often, and we're taught initially that we need to learn these, we need to memorize them. I remember when I used to teach it at the university, we would expect the students, if they wanted a high grade, to remember the sensitivity and specificity of the tests that they were testing in their final exams. So there was a lot of emphasis placed on those tests, but we know now that there are a lot more things to consider than just clinical tests and the manual tests that we can do in clinic. So I'm going to go back to that at the end of this. So I'm going to have a look at reliability first, and then validity. So a reliable test means that you've got consistent findings no matter who's done the test and when it's done. Okay, so it should be repeatable. And if I have written a specific protocol for a test, and then I've written it up in a paper, and somebody else reads that paper, reads my method, and does exactly the same way of testing, they should get the same results as well. Okay, and that shows you that it's a very reliable test. So I'm just going to give you an example. So we've got Dan there doing it. I don't know whether you were expecting that, but we've there are two types of reliability. So we've got intra-tester or intra-rater reliability, and so I've just done a test, the knee to wall test, and we're going to talk about a little bit more about that later on. So he's done it there at 10 a.m. and then he's done it again at 3 p.m. And what we want to see is that test reliable when he does it in the morning and then he does it again in the evening? Does he get the same result? So is there reliability with that single person? And that's an intra-tester reliability. Okay, so that's something that you might see in research papers, intra and inter-tester. And we'll have a look at the next one. We've got a guest. We've not had him on. We should bring him on. So we've got Rob, Rob, and Dan, both doing a test at the same time. And this is inter-tester reliability. So they're doing the same test. They're both doing it at the same time. And we're seeing whether they both get the same results. Okay, so we've got two or more people testing the same measurement at the same time, and then seeing if their results are different. So if they agree on the results, then we would say that test has good reliability, has high reliability. And these are this is how it's portrayed in the literature. So there's loads of fancy ways that they look at to work these figures out, but I think for just for ease, we just say there is an ICC value, and there's other ways that you can measure it as well. But what we're looking at is ICC values, so intra-class correlation coefficient values, where 1 is they agree perfectly and 0 is they don't agree at all. Okay, so if we had Rob and Dan doing a test and they did it again and again and again, and they kept on getting the same results again and again, that would be a very good test. That would have high ICC value between 0.81 and 1. Okay, so we would consider that to be a good test. Okay, good reliable test. So here's an example of that. So this is the weight-bearing lunge test, or the knee to wall test that we mentioned earlier. So you can do this two ways. You can do it with an inclinometer, so a measuring device that measures angles, and you can also do it with a ruler, so that you can measure the distance from the wall to the toe. So you can see that on the diagram on the left. So we've got the inclinometer placed on the mid part of the shin, and then the distance from the wall to the big toe, which I think is letter D there. So you can measure the distance. So what this paper was looking at was, is there any difference with the ways that you test it? So if you use an inclinometer or a ruler, and does it differ if the same person does it again and again, or if different people do it again and again? And I've highlighted there on the right hand side, you can see for the distance measurements, which is the top row, and then right on the top we've got inter-rater reliability and intra-rater reliability of person A and person B. And you can see that the scores there for this particular test, so for a distance measurement, the ICC values are at 0.99. So they're nearly 100% in agreement. So this is a very reliable test. Okay, so if I did it, you did it, somebody else did it, doesn't matter what day of the week they did it, we would get very, very similar results, okay, in the high 90s. And that is also the same, even though it's slightly less, it's the same for the angle measurement as well. Okay, so whether you choose to use the inclinometer or the distance measurement, it doesn't matter. The reliability of that test is still very good. Okay, so that's an example of that. This is an example of where reliability is not so good. So this is a systematic review. In the end, they ended up with 9 studies. I think it was osteopaths, goddamn osteopaths. They were checking out to see whether osteopaths agreed on pelvic morphology. So they were looking at specific bony landmarks around the pelvis and the lumbar spine. And I've just picked out the ASIS here. So we've got 9 studies. And the inter-rater reliability, so me doing it and then Dan doing it or whoever, the reliability for palpation agreement was minus 0.01, okay, to 0.19. So there was sometimes a negative correlation with that agreement. Okay, so it's not a very reliable test between people, even intra-rater, so me doing it and me doing it again, it was slightly better, but it was still considered just a fair palpation assessment. Okay, so that's where reliability of testing is not so great. So then we look at validity. So the validity is the ability of the test to accurately measure what it sets out to measure. And this is why Dan went first, because introducing you to specificity. So specificity rules things in, okay? And if you do, well, this is an example of the pivot shift test. I don't know whether there is another paper out there. This is a meta-analysis of knee exams for anterior cruciate ligament rupture. And they looked at the pivot shift test and they said it had a 98% specificity. Okay, so if you tested 100 people, 98% of them would have that condition. Okay, so that is it's a valid test because it does what it says it should do most of the time. Okay, pretty accurate. So this is kind of putting the two together then. So you can have a test that's very reliable. So I do a test, but I get a good result. Someone else does the same test, they get the same result, and it's very reliable, but it might not be very valid. Okay, and an example of that is if you've got a weighing scales that are not calibrated. So you will consistently get the same result when people step onto the weighing scales, but because it's not been calibrated, the result is wrong. So the result is not valid. Okay, so you can have reliability, good reliability, but no validity. That doesn't make a very good test. Okay, then you can have a valid test, so it does what it says it should do, but it may not be very reliable, so people get differing results. So an example of that might be the pivot shift test, which is a valid test, but then it's hard to do well depending on how experienced you are. So the reliability may rely on your experience as a practitioner. Okay, so and as you get better, it may cluster the results that you have towards a more reliable test. But if you're a novice rater, doing a test like that, it may not be as reliable. Okay. And then, so what we're aiming for, hopefully, is the bullseye. We're aiming for a valid test that does what it says it should do, and it's repeatable. So you can do it again and again. Doesn't matter when you do it, who does it, we get the same result. Okay. So that hopefully kind of encapsulates all of what we've just talked about there. But then we got this as well. So there's a really cool paper from back in 2008, I think it was, a guy called Grice working with Lee Harrington up in Manchester. They looked at the ASIS and PSIS inclination on cadavers. So they took cadaveric specimens and they measured the angle of inclination of their pelvis. And what they found was that the angle of inclination differed from side to side on the specimens. So if you're using the ASIS as a measurement to measure pelvic morphology on a patient, they may already be 11 degrees of inclination difference just purely because of the differences in the anatomy. Okay, so nothing to do with that they're rotating on one side, nothing to do with their muscle spasms or anything like that. It's purely their structure, their pelvic structure is different from one side to the other. Okay. They also found that there was a 16 millimeter difference in innominate heights from right to left. So when you measure up someone's iliac crest, naturally in the 30 cadavers that they found, on average, there was a 16 mil difference. Okay. So now we're starting to question the validity of assessing pelvis inclination and whether actually measuring it is, and we notice that it's slightly off, for want of a better word, is that actually telling us that their pelvis is off? Okay, because looking at these cadaveric studies, it's less likely. Okay, so then we've got a question. So if palpation of the ASIS is unreliable, so people can't agree where it is, and it lacks validity because we're different from side to side, then what does that mean for every test that where we use the ASIS as a standard marker? Now, where does that leave us in the clinic when we're getting taught these tests where you have to palpate PSIS and ASIS levels? It makes you think about what you're doing, and it will change the way you say things and the way you do things. Okay. And just going back to the very beginning, so this is from the wine editorial. So clinical diagnosis is like producing a great wine, is very complex. Yeah. So we've just looked at the complexity of the test that we have available to us. It requires an appreciation of the data that can be gathered within the nuances of patient interaction. And that's where this comes in. So this is adapted from Ben Cormack, and probably many other people have used it as well. But you can have elements of different areas of a patient's life, which is affecting how they're coming into clinic. And then the clinical testing, if it's not valid, if it's not reliable, if it lacks specificity, sensitivity, then we're missing a lot of the problems. Yeah, and we're not focusing on the right areas. And sometimes it can be a biomechanical issue. Sometimes it can be a social issue. Sometimes it can be a psychological issue, and it will be different for everybody. Okay. So have we, for years, been focusing on the wrong things? There's a question for you.
Brilliant. Thanks, Mike. So, yeah, fantastic. I just wanted to add in a few more things now. Is that the right time, Mike? Have you finished?
Yeah, cool. Yeah.
The first thing is that I've noticed from reading studies and looking at studies on special tests that often when a new test is first presented, the originators of the test report that the test is very good. They report that their test has high specificity and high sensitivity. However, and I've seen this a few times in the research, when the tests are then assessed by more independent researchers, the the specificity and the really the validity of the test is really seen to be much lower than it was first presented. So we can question the research because often the test is said to be better than it is until it's questioned independently. The other thing that I see in the research is what is the gold standard? So with these special tests that we're doing, you know, we're pushing, we're pulling, we're stretching something. The gold standard is usually whether there is pathology within what we're testing, whether that ligament or that muscle or that meniscal tissue. And that's usually the gold standard is MRI. All right. So MRI shows if there's any issue with the structure that we're testing. And then if you look at the test results that were done clinically and you look at the MRI imaging results, you can then work out what the sensitivity and specificity is for the test. But Mike's just been talking about the fact that often structure is not as involved as we perhaps thought it was. Sometimes structure is heavily involved and sometimes structure is not involved in the reporting of people's pain. So if the tests are using MRI as gold standard, yet we're saying structure isn't always the cause of people's pain, then it further questions the validity of the very research which is assessing the tests that we're using. The other thing, Mike, you mentioned is who does the tests. So I like the knee to wall test, the dorsiflexion lunge test. It's a great test. And in that test being really reliable, that's the kind of test that you could get your patients to do themselves at home, because with such high reliability, they should be able to do it and you know, get accurate results. And then furthermore, at the moment, we can't assess patients with the things that we're talking about. So we're getting patients to do it themselves, or we're getting patients' partners or mums or dads to do it themselves. And one of speaking to Gemma from the Rock Tape team recently, and she tried to get a wife to do a medial ligament test on her husband's knee, and it just didn't go very well, apparently. So, you know, this is one of the things we should consider at the moment, is obviously trying to do special tests when we're not actually able to do them, when we're trying to getting patients to do them, can certainly present some challenges. And there was a few other things that I wanted to talk about, but I think I'm just going to slow down now to see if there's any questions, because the other things I wanted to talk about are actually in a video that I've pre-recorded on the Physio channel. So I can just share that video with people, Mike, and then
cool. Yeah,
that'll allow us now to take any questions from people. So guys, I wondered if there are any questions on what Mike and myself have talked about.
Stunned silence.
Stunned silence. I'm just going to get that video copied across. Okay. All right. So I think, guys, in the chat, the link there should take you through to the Physio channel video, but don't disappear just yet. We're just asking if there's any questions really on where we go from here with regards to special tests, because I think a lot of people are saying now that they're not special. But actually I disagree. I think that special tests are special. We just need to put them into context. We need to make them fit with the overall jigsaw. And also what special tests can teach us is far beyond what we're looking for when we test the patient. They can teach us many things about the underlying anatomy, what actual structures we're testing. And often the special test is linked to the aggravating factors that the patient reports. And if we can build up a greater knowledge of the type of biomechanics that might cause problems, then special tests are one way to help us achieve that as well. So
had a couple of questions through, Dan. So Rebecca said, do you ever feel you haven't done enough testing?
Yes, great question. The special tests, even if you're doing tests which aren't very specific or even very reliable or valid, the very fact that you're doing some tests of the right area starts to build up rapport and confidence with a patient. If you have not done enough tests, even if you've just done one or two brilliant tests, if the patient feels that you haven't properly assessed them, then you're really unable to move forwards with your treatment, because they won't trust your approach if they don't feel they've been fully tested. Also, I do miss tests. I'm sure you do as well when you're assessing, Mike. Sorry, maybe you don't. Take that back. I'm sure you don't miss any tests when you're testing people.
Well, I was going to say that I don't. I do a lot fewer now than I did when I very first graduated.
Yeah, me too. But I'll often spread them out over more than one session.
Yeah.
So I might think, oh, I should have done this as well. So I spread those tests out over different sessions. So that's that question. We got another. Thank you, Rebecca. Another question from John. Where is the best place to quickly check test reliability? Oh, that's a great question. I've got the answer to that in front of me. There's a lovely little book. I'm just going to turn my light on a minute. A lovely little book, which I'm going to show you on the screen here. A light on so you can see it.
Yeah, that's a good one. It's
a little pocket book written by some physios that I know from, they ran a course as well in this country. A very good book, Special Tests in Musculoskeletal Examination. It doesn't cover the spine, but it covers the peripheral areas as well. Another good place to quickly look up online is Physiopedia as well, which is often a good source of information and has some references on there that you can refer to as well. So yeah, that book and Physiopedia.
Yeah, I think that's answered Peter's question as well about data on tests. Yeah. There was another book, a green one, Clinical Musculoskeletal Tests by Fox, I think it was. We used to use that as our on our reading list. That was another good one. It had loads and loads of tests in, and then it had several papers showing the sensitivity and specificity of the test rather than just one. Because I know some books they don't. Well, sometimes the research hasn't been done, but some books are very limited on the research that they show you. But this one was pretty good. It had at least 3 or 4 references, I think, for each test that was in the book. So that was a good one. But like we've done today, though, I think it's all very well having that information in a book, but it's being able to understand what that information actually means. So hopefully today has helped with that a little bit. We've got opinions on cluster testing as well from Jake.
Yeah. So Jake, I mentioned that in the video that I've put up from the Physio channel. Cluster tests make sense, and sometimes the research frames cluster tests as well. So there'll be cluster testing for, say, the meniscal injuries of the knee, and the clusters won't always just be mechanical musculoskeletal tests. The clusters can sometimes be the presentation of certain symptoms, mixed positive orthopedic tests as well. So cluster testing is good and it makes sense. And obviously, when you've got more than one test, you've got a greater ability to be more sensitive with the test, in that you're less likely to miss something if you do a few tests for a particular problem.
I think I really liked what you were talking about earlier, Dan, as well, about the tests become part of the treatment. I think that's really important. Because sometimes in the case history, 99% you know what is going on with someone, but if you just went straight into a kind of treatment session or exercise session without any examination, then the trust would be in my experience would be a lot lower. So actually physically going through that examination is part of that whole treatment process. I think that's a really important point. That's really good.
Now, Marcus has hit us with a curveball here. Hi, Marcus. Thanks for joining us. So I think you're referring here to Ida Rolf's comment where she said, where you think the pain is, it ain't. That's the first part. And then is indeed how we should be looking at the body client. Oh, right. Yeah, okay. You're suggesting, that's how we should be looking at the client, where okay. So reading into that, Marcus, I think when you do special tests, they obviously tend to be very focused on the tissue that you're working with. So the idea is to try and detect the pathology. However, the cause could be something further afield. And I think one of the most obvious links, Mike, is the link between the hip and the knee.
Mm-hmm.
So we often know that a dysfunctioning hip can put more stress on the knee. And therefore, if we detect, say, a patellofemoral joint issue, then actually we might also be looking for any dysfunction at the hip, or target the hip as a source of an area where we can treat in order to help alleviate the symptoms at the knee as well. So, I think we should definitely think about that in that with special tests for specific things, we should also try and broaden our testing to include certainly, the joints above and below to see if any problems lie there. Yeah, that's a great comment. Thank you.
Yeah. I think that's really important. I think, however, though, you've got to be careful with if someone has come in with a knee issue, and then you're sure as anything it is coming from the hip, and you start doing a lot of your treatment on the hip when they've come in with a knee problem, that takes a bit of explaining to your patient. So sometimes you've got to give them a little bit of what they want and a lot of what they need, and drip feed that kind of biomechanical approach across several sessions. I think if you try and do that in the first session, they might not come back. You've got to build that trust in you that you know what you're talking about. So I think that's important too.
Yeah, to prod the sore bit. That's from the patient's point of view. One of the most important special tests is to physically clarify with the patient that you know what hurts. And if that's not a special test, then it's a prod in the right area, so that they know that you know where it hurts, and then obviously take it from there. Poke the bear. Thank you. So Natalie Whitaker, do you find that hypermobile clients are hard to work with? No, yes. I'm not really sure how to answer that one, Natalie. I can appreciate from a physical point of view that the laxity in the joints is going to somewhat alter the normal values that you'd sort of the normal feelings that you'd expect, the normal end feels that you'd expect. So it's important, of course, when doing special tests to check the other side, obviously, but also to see if there's any other, underlying reasons. So if they've already had a previous injury or an operation to their shoulder or something, then this might, of course, affect the results of a test. But certainly with hypermobile clients, there are tests that exist, though, aren't there, Mike, for clients that would be classed as hypermobile? For example, at the shoulder, you might do an apprehension test where you abduct and externally rotate their shoulder and see if there is an end feel to the external rotation, if they're apprehensive about that movement, or if there appears to be no end feel and the movement just kind of keeps going and is what's described as an empty end feel. So there are special tests as well, which are kind of for instability or hypermobile clients as well. So
we've got Bonnie in the group as well, who's just answered yes to that. She's I hope so Bonnie's been on my course, and we a lot of the tests that we did clinical test wise, she would pass them all because they are usually kind of joint restriction tests and mobility testing, and of course a hypermobile patient will pass most of those, all of them, and but so the issues aren't in the range of motion, because that's not a problem. It's they often from the patients I've treated a few with EDS before, and the problem is not the mobility, it's pain from muscle spasm, because they're trying to brace the joints, so that we don't really, the clinical testing that we've done, they usually pass it all. It's usually fatigue, for muscle pain from fatigue. Thanks, Bonnie. So it was interesting because we did some endurance testing and strength testing with Bonnie, and that was actually more gave us more information than the clinical assessments did.
Okay. Wow,
Excellent.
fantastic. Thank you. Should we take one more question, Mike?
Yeah, sure. Let's have a look. It's got Thessaly's from Sam Griffiths. Can Thessaly's test aggravate a suspected MCL injury?
Yes.
That was a nice, easy one.
Yes. Yes, it can, Sam. And therefore, that makes the test, perhaps a little bit less specific, because it can get mixed up with other things, causing a positive from that result as well.
Brilliant.
So, yes. All right.
That was great, Dan.
Thanks,
Brilliant.
Mike.
No worries. Thank you, everyone, for your questions. Really good. And tonight's talk was born from a question from last week. So that's why we decided to do this session. So if there is anything that you want us to cover, then either through the Physio channel or through Movement Therapy Education, drop us a note, and we will do our best to cover whatever it is you want to see. So thank you again, Dan.
Thank you, Mike. That was great.
Cheers,
Thank you,
guys.
guys. Thanks for joining us. We appreciate that.
See you next Monday. Thanks, guys.